Good afternoon. Ooh. Yeah, a little variation in size there, height. And again, thank you so much for all coming. It's always fun to do this once a year before May is Melanoma Awareness Month, and that's why we do this. So I'm here to talk about metastatic melanoma because there's so much that's gone on in the last few years. And my topic is metastatic melanoma, no longer a death sentence, because when I first started doing this disease, and I've been here at NYU now for 16 years, I didn't have a whole lot of tools. And patients would come see me with metastatic melanoma, and we would do clinical trials, and we would do research, and the outcomes would be dismal. Patients with metastatic melanoma 16 years ago had a 5% chance of surviving their disease, which is really very depressing. When I show you now what we've been able to do, really only over the last 5 years, is change that survival from 5% to about 50%. So that's really pretty incredible when you look at those numbers in such a short period of time. So when we talk about metastatic disease, what do we talk about? Well, less than 5% of patients survived up until 2011 when we had all these new treatments. 50% of patients who had metastatic melanoma would develop brain metastases. So this meant that the cancer would spread through their bloodstream and make a home in their brain, which made it even more difficult to treat. Before 2011, we only had 2 treatments, which was chemotherapy and an agent called interleukin-2, which had to be given in an intensive care unit because it had so many side effects. And it really didn't change how long people lived. So we would make people sick really for not a whole lot of benefit. We'd maybe stop the cancer for a little bit, but really not change how long they lived. Well, in 2011, there was the evolution of a new immunotherapy medicine called ipilimumab, or Yervoy. We also found that 50% of patients, when their melanoma spread to other parts of their body, their tumors will acquire a genetic mutation called BRAF. Now, again, it's important to know that this genetic mutation within the tumor is not a genetic mutation that you can spread to family members, but it is a target where we can develop medicines to attack that target to control the cancer. And so in 2011, we had the FDA approve an immunotherapy medicine called ipilimumab, as well as a BRAF inhibitor called vemurafenib. And with these new therapies, we now have changed survival for patients with metastatic disease to over 50%. So we're going to talk a little bit about immunotherapy because immunotherapy is really something that is a treatment that's for every melanoma patient. It doesn't require that you have a specific mutation, very much like the BRAF mutation medicines. If you don't have that BRAF target, those medicines are not going to help you. In fact, just the contrary. If you give a patient with melanoma a BRAF medicine and they don't have a BRAF mutation, you can actually accelerate the growth of their tumor. So it's very, very important to make sure when you select these medicines that you've really adequately checked the tumor to make sure it either has a mutation or it doesn't. So immunotherapy, what does that mean? Well, immunotherapy means that we try to generate the body's immune system to attack the tumor. Very, very different from chemotherapy because chemotherapy is just giving medicine that attacks cells that are rapidly dividing, and it doesn't differentiate between normal body cells and cancer cells. Anything that's rapidly turning over gets killed by chemotherapy. And so that's why not only does cancer get better, or some cancers get better with chemotherapy, but people will also lose their hair because your hair follicles are rapidly dividing. And so that's why chemotherapy is associated with hair loss. Immunotherapy is very different. Immunotherapy, because it's targeting your immune system, does not give you chemotherapy side effects. So no nausea, no vomiting, no hair loss. You don't walk around looking like you're a cancer patient. You look like you're a normal person. However, the medicines are not without side effects. And the side effects that immunotherapies can give patients are what we call the itises, or things that cause inflammation. So dermatitis, meaning rashes, pruritus, meaning itching, colitis or diarrhea, hepatitis, inflammation of the liver, pancreatitis, inflammation of the pancreas. Put an itis on the end of any word, and that's one of the potential side effects of these medicines. Some patients will go through these treatments and have no side effects. Some patients are very sensitive and have side effects. But the important thing to know is if you have side effects or if you don't have side effects, it does not determine whether or not you respond to the treatment, because a lot of people will say to me, well, if I don't have side effects, does that mean that the medicine's not working? No. And to the contrary, if you have lots of side effects, where you have lots of diarrhea or you have lots of itching, it doesn't necessarily mean that the medicine is being effective against the tumor. So how does this work? Well, I have a pointer. Okay, so this is what's called your antigen-presenting cell. It looks like a big purple fried egg here. Your antigen-presenting cells are the cells that try to get your body's immune system to become activated. So this is your T cell. Yeah. Okay. This is why I have absolutely no eye-hand coordination, nor am I a surgeon, because I can't even work. There you go. Okay, so this is a T cell. Your T cells, again, these are the cells that are going to be the attack cells. So you want to get these revved up and activated, and you want your body to produce as many active T cells as it possibly can to attack your tumor. So here's your T cell, and you can see this tuning fork on the inside of your T cell. Well, that's a receptor called the CTLA4 receptor. That's the brake. So when you activate a T cell, your T cell interacts with your antigen-presenting cell. The T cells get revved up. They secrete all kind of what we call cytokines or substances that will generate a bigger immune response, stimulate more T cells. Well, the T cell is a very sensitive thing, and it likes to protect itself because too much immune stimulation can give you what? The itises. So here's the tuning fork. The tuning fork comes out and attaches to the antigen-presenting cell, and what happens? Things get shut off, so the T cell shuts itself down. Well, we've been able to create a medicine called a monoclonal antibody, or ipilimumab, that blocks and attaches much more strongly to this receptor when it comes out and allows for those T cells to remain active. So this was the study that we did, and this was for patients with melanoma that had lots of prior therapy. So they had no options, and we said to them, well, here's your option. Take it or leave it. We have nothing else. And so we figured if we combined this medicine, this ipilimumab medicine, with a vaccine, and again, what's our thinking here? Our thinking is if we take a vaccine, the vaccine is going to drive the immune system to the tumor because the vaccine is generated against the tumor. So we're thinking, okay, active immune system, let's position it to be driven right to the tumor. So that's why we put so many patients on this one arm thinking, again, as researchers, we like to think we're smart, and many times we're found out that we're really not very smart, that this would be the winner. So then we compared it to 137 patients who just got the antibody and 136 patients who just got the vaccine. And what did we see? We saw that there was absolutely no difference between getting the ipilimumab or the Yervoy with the vaccine or without the vaccine. Patients clearly who got the vaccine did not do anywhere near as well as the patients who got the ipilimumab or the immunotherapy. And what we saw was that patients here at 1 year, 50% of patients who were predicted to not be able to survive another 6 months were alive at 1 year. Pretty exciting. So we doubled survival compared to the vaccine where only 25% were alive. And even more exciting is here we are at 2 years, 25% of patients were alive at 2 years, and the lines stay flat, which means those patients are still alive today. And so this was very exciting to us because not only did it say that we could control tumors, but we're actually changing how long people live And maybe we can put people's tumors into remission. Maybe they never go away. But if we can turn them off because of an immune response that shuts that off, they can live normal, healthy lives, and they're not going to die from their melanoma. So let's talk about the itises that these medicines can cause. And we talked about the GI, which is the diarrhea. We talked about the hepatitis, or the inflammation of the liver. We talked about the skin issues, which is itching or rash. Neurologic issues are exceedingly rare. But the endocrine issues, we can give patients thyroiditis. We can cause their thyroid glands to go a little wacky. And what happens when that happens, if your thyroid becomes overactive, you lose weight. If you become hypothyroid, you start to gain weight and you feel sluggish. So these are clues that when we take care of patients with this, we always have to ask them, how do you feel? In fact, hypothyroidism is one of the easiest things to look at because you suddenly notice that patients are gaining weight very, very rapidly, and they're going to tell you, and I swear I'm really not eating a whole lot more, I just can't lose any weight. Okay, nice. So when do these things happen? The interesting thing when you give patients immunotherapy is that side effects don't always happen as soon as you give them the medicine. And why is that? Because again, you're generating an immune response. So your immune system doesn't always give you side effects until later on. So here's the most common, which is the diarrhea. And diarrhea usually happens about 6 weeks in. Well, that means patients have already gotten 2 treatments. So it's not an immediate side effect. And here we were talking about the endocrine things or the thyroid things. Those don't happen until almost 3 months later. So you have to constantly be surveilling and watching patients because these side effects can happen at different times. One of the really unique things about immunotherapy is that many times tumors can get worse before they get better. And that can be very scary. So if you look here, this is tumor, and you can see the tumor on the CAT scan. Here's week number 12, and look at how much bigger these tumors are. Look at how much bigger this tumor is on CAT scan. And many times we'd say, oh my goodness, this is not working, we need to stop. But you have to put it in the context that this is immunotherapy, and you have to be patient. Well, here you go, week 16, which is only a month later. Look at how much better. And here, gone. So you have to be patient. And it's very, very difficult for patients and physicians to be patient. But if the patient is feeling well, you have to believe that you have to just wait, because many times you'll be right and things will get better. Many times we're left with patients who still have stuff on their CAT scans or stuff on their legs. Many patients who have tumors on their legs or their arms or their bellies will still have purple spots that are left. And how do we know that that's not cancer? Well, what we've done in these studies when we worked with these drugs is we did biopsies. And we did biopsies of what we called residual, what we thought was residual tumor. And what we found out that there's no tumor there at all. These are all normal immune cells. You still have the pigment, but there's no cancer there. So that's what makes us feel much more comfortable in telling patients, you can still have a little bit of stuff on your scan or some stuff on your body, but it doesn't necessarily have to be active cancer. Well, following on the tails of ipilimumab is a new antibody called anti-PD-1. And there are 2 of the anti-PD-1 agents that are approved now. One is called nivolumab, the other one is called pembrolizumab, and they essentially work the same way. And I want to show you, I think in the next slide, yes, how they're different. Because ipilimumab works in one part of the immune system, anti-PD-1 works on the other part of the immune system. And the way that most of these drugs are given is either you give the ipi first, and then you give the PD-1, or you give them together. And why is that? Because remember, we've got our T cells that are talking to our dendritic cells, so those dendritic cells are activating and stimulating those T cells. So you got all these, I like to call them my fighter pilots, and they're out there and they're ready to attack But what happens is here's the tumor. Well, the tumor is a really smart thing, and it has a force field around it. And that force field is essentially the PD-L1 antibodies that cover the outside of the tumor. Well, if we now have a medicine that attacks the PD-L1 antibodies, well, guess what? Now we can bring down the force field. We put holes in that force field, or we get rid of it completely. So all those fighter pilots can get in there. Everybody see Independence Day? You know, where you figure out how to know how to get in there, kill the tumor. Star Wars, bring down the force field, get the planes in, same idea. And it works great. So this is what we saw. These are patients who got ipilimumab first and then went on to PD-1. And we saw that, look at how many patients got benefit. And the blue lines are patients who continue to have benefit. Well, and again, you can see these, what's called a waterfall plot, again, showing that you can see there's more lines underneath than on the other slide, and these are for patients who got therapy together. What's important to know is when you give both medicines together, they work a lot faster, but you get a whole lot more side effects when you give them together. And I did want to touch on vaccine therapies, because if one more patient comes into my office and says, did you see 60 Minutes? And here's the article on the polio virus, can I have it? My answer is, these are things that we are working on, because viruses are very good vehicles to help us attack cancers. So one of the more advanced vaccines that's out there is called the T-VEC vaccine. And that uses the herpes virus or the cold virus to help get medicine into the tumors and, again, trigger an immune response. So how does this work? So here's your healthy cell, and we put the virus into the healthy cell, and the healthy cell gets rid of it. Just like when you get a cold, you get a virus, your healthy cells know how to get rid of them. Well, what happens when you put the virus into a tumor cell, it replicates. And so, again, when it explodes here, it releases all these antigens and stimulates your body's immune system, further triggering more of an immune response. And again, remember our friend the dendritic cell. Now the dendritic cells get stimulated, attached to those T cells, and so now you have all these proteins floating around. You have all these happy T cells that are active, and so all your fighter pilots are out there, again, trying to attack the tumors not only locally, but also in distant parts of your body. Many of these therapies, these virus vaccine therapies, require that the vaccine gets injected directly into the tumor for it to work the best. So these therapies are not for everybody for that reason. These are some of the research studies that we're doing, and I want to try and stay on time, so I'm going to go quickly to targeted therapies. And remember, in the beginning, we talked about BRAF therapy, and BRAF is a mutation that's found in 50% of patients who have melanoma. Why is this important? Because we know that if we develop a medicine that blocks this target, we will prevent the melanoma cells from replicating, and guess what? Cancers die. So we have two medicines that target this BRAF, vemurafenib and dabrafenib. They're pills, which makes it a little bit more convenient. However, all medicine has side effects. So what are the side effects? Well, joint pain, fevers. These medicines can also cause new squamous cell cancers to develop on your skin. So it's very important, especially during the first 3 months of therapy, that you're being surveilled by the dermatologist, because if you develop a skin cancer, it gets taken off and you don't have to worry about it. You also do not need to stop your medicine if you develop a squamous cell cancer, because we expect these things to possibly happen. We know, however, that if we give you a BRAF medicine and now give you another medicine that blocks a little further down called a MEK inhibitor, you don't get any of those skin cancers because it balances themselves out. So many of us will give patients 2 pills if you have a BRAF mutation to control the cancer, which controls the cancer better and longer and actually decreases the potential side effects that you could have. So again, what's important is all the lines underneath the curve. Very impressive. And these are some of the side effects. You can get skin cancer, squamous cell skin cancer. You can get warty lesions, and you can get what we call hyperkeratosis or calluses that develop on the bottoms of your feet and even on your hands from these medicines. Don't care about that. So I wanted to just show you some exciting cases. This is a patient who had an early stage melanoma, but it came back. He was found to have spots in his lungs. He was given immunotherapy with ipilimumab, and after we did repeat imaging, he was found to have, unfortunately, more disease and new tumors in his brain. So these are his pictures. This is his brain. This is before, and this is after. And why do I show you this? Because this is a patient who did not respond to immunotherapy, but responded to targeted therapy. This was his lung mass, all gone. And the good news is the patient has been off therapy now for 3 years. He is very much alive. He's back to work as an attorney. And he's teaching law school again, and has absolutely no side effects. This is another good story. This is a woman who had a melanoma on her arm. She was fine until 2011, which was 3 years later. She had surgery in June, but then almost a year later, she had some belly pain and was found to have the mass came back. She went on a clinical trial, which did not help. So then she went on another clinical trial with the PD-1 antibody. And as you can see here, this was her tumor. And I dare you to really try and find it here. It's eensy-weensy-teensy. So despite failing one immunotherapy, this lady responded excellently to anti-PD-1, and I will argue that she probably has no disease. She has what we call that schmutz that we see, and it's probably a tumor that's really just nothing more than scar. She's now retired, and she bought her dream house at the Jersey Shore. Didn't know you were going to be here. These are some other interesting clinical trials that we're performing here at NYU. One of them is using a conjugated antibody. I bring that up because everybody says, well, you've got a 50% survival rate, aren't you there? And the answer is no. We don't cure 100% of our patients, and until 100% of our patients are cured, we still have work to do. And so we're looking at antibodies. Conjugated antibodies are essentially, I describe as a Trojan horse. We take a protein that is unique to a melanoma cell, and we are able to inject a toxin into that protein. That protein then attaches to the melanoma cell, gets engulfed by the melanoma cell, and then releases the protein directly into the cancer cell. So it's a really neat way to provide targeted therapy right to the cancer cells. And so those trials are going on now. And then in conclusion, I hope I've shown you that we've made some pretty amazing strides and people are surviving despite the fact that they get metastatic melanoma. And many patients are now considered survivors. However, we have not reached 100%. And so we will continue to keep doing research until I don't have to come give this lecture anymore. Thank you. And I just need to acknowledge every patient who has agreed to participate in the research here at NYU. This is our large melanoma research group of investigators, both clinical as well as basic scientists. We all work together to make things happen here. And this is my clinical team that provides what I would consider the best melanoma care in the country. Thank you.